Bismillah ar-Rahman ar-Rahim. Good morning, our dear students. Today we will discuss a very important topic, which is organic brain syndrome. As usual, when the patient presented with somatic symptoms like palpitation, and he was presented to the cardiologist in his clinic, and after examination the cardiologist will find nothing by the examination, and he will advise you to be referred to a psychiatrist. And now there is an exclamation mark in your mind. What is the relation between these physical symptoms, which is palpitation, and psychiatric illness? And our dear friends will discuss with you this relation, which is called psychosomatic symptoms. The patient is presenting with somatic symptoms due to underlying psychiatric illness. It may be depression, it may be anxiety, and what else. But today we will discuss the reverse. The patient is presented with psychiatric manifestation due to an underlying organic illness. So the patient will go to the psychiatrist, and psychiatrist will examine the patient, and he will refer him to a neurologist to discover the underlying cause, and they will form a team to treat the patients. The psychiatrist will treat the psychiatric manifestation, and the neurologist will treat the underlying cause. So there is somatic symptoms due to underlying psychiatric manifestation and psychiatric manifestation due to underlying organic disease. In the second story, it is called organic brain syndrome. This is in the old classification. But in the DSM-4, it is called dementia and delirium. And the last nomenclature and last classification by the American Psychiatric Association, it is called mild and major cognitive disorder, which is dementia separated from the delirium. So organic brain syndrome includes dementia and the delirium, but the new classification separated into two disorders, delirium and mild and major cognitive disorder, which is the dementia. Dementia and the delirium share some of the clinical signs and symptoms, and there is three cardinal features which can differentiate between both of them. These three cardinal features is always the focus of our MCQ questions, because we can give you the same story, but we can put the three cardinal differentiating points to help you to differentiate between the case. Is it delirium or dementia? The three cardinal differentiating points between dementia and delirium, number one is the onset. If the condition is started gradually, it is dementia. What is meant by gradually? The family, because the patient has no insight, the family will be presented to you, and he can't make a line of demarcation between normality and the start of the illness. Sometimes they say the condition started since last Ramadan, and other member of the family will say, no, it is since 4 months when I am phoning him from Saudi Arabia, and I want to be assured about my dad. I find him not doing well with me on the phone. And the other one, he will say, no, this is since 1 year. So no one can give you a sharp onset. This is not the story in delirium. Delirium, there is sharp, acute onset. The family will say that yesterday, after the patient wake up at the evening or in the morning, he started to complain from this and this and this. Or the condition started sharply since 2 days. So number one is the onset, gradual onset or insidious onset, and acute or subacute within days or weeks. This is number one. Number two is what you can call the state of consciousness. Patient with dementia has clear consciousness, like me. Now I am talking with you in clear consciousness, and I am very attentive. But in case of delirium, the cardinal sign is disturbed state of consciousness. You can call the patient confused, cloudy consciousness. His consciousness is not clear. Okay? Number three, after the two cardinal symptoms, is the reversibility. Dementia is a progressive illness. It is not reversible. It is irreversible. And during treatment, you are keeping the course stationary. This is the best outcome. Or you delay the progression, making it slowly progressed. But in case of delirium, if you are treating the underlying organic cause, the condition is reversible. The patient returns to the previous state of cognitive function. So this is the three cardinal differentiating points. And they are sharing with each other the cognitive dysfunction symptoms and signs. Okay? So we can describe patients with the same cognitive dysfunction, but we will put one of the cardinal symptoms like acute onset, like a disturbed state of consciousness, like reversibility, in between the sentence to discover the correct diagnosis. I want you not to be confused between reversibility and fluctuation of the condition during the day. Because in case of organic brain syndrome, dementia, or delirium, there is waxing and waning of the symptoms and signs. In another word, the condition is more worse at times and less worse at times. So it is not reversible. This is fluctuation of the condition. In another word, the patient is more worse at night. This is a cardinal symptom in the organic brain syndrome. The condition is more worse at night. And this is called in clinical symptomatology sundowner's syndrome, which is when the sun is downing at night, the condition is more worse. And the condition is to some extent better in the morning if the patient sleep well. This is the reverse of functional disorder, like schizophrenia, like depression, like bipolar disorder. When the condition is more worse in the morning, you will find, especially in psychotic depression, the patient is more worse in the morning. But in organic brain syndrome, the patient is more worse at night, which is the sundowner syndrome. And this sundowner syndrome is more evident in delirium. Okay? Now, after this introduction, we will start dementia. What is dementia? Dementia is devoid of brain. Dementia is persistent state of serious cognitive and behavioral and emotional deterioration from a previously higher level of functioning. Okay? This dementia should not be misdiagnosed as mental retardation, because there is a line of demarcation between dementia and the mental retardation. Mental retardation usually occur or always occur before the age of 18, and the patient doesn't reach full cognitive capacity. He usually stops at a certain level and can't develop his full mental capacity. But dementia started after the age of 18. After reaching full cognitive capacity, then the condition will deteriorate from the previously normal. That is why you can find a common underlying cause in dementia like hypothyroidism. If hypothyroidism occurs before the age of 18, it will cause mental retardation in children. But if it caused or it happened after the age of 18, you can call it dementia, because the patient reached full cognitive capacity at the age of 18. So age of 18 is the first landmark in the diagnosis of dementia. It has to be after that. We have different types of dementia. If the dementia is called Alzheimer's dementia, and you will know the classification of dementia later, the condition will start by memory loss. And initially, memory will be in the form of difficulty in learning new information. As all of us know, there is working memory. You are talking with me now, and I'll put by the hippocampus this conversation in the long-term memory. You are now sitting in front of me, studying this lecture, and the hippocampus, which is a specific area in the brain, which is responsible about changing new information from working memory to long-term memory. This function will be lost early in the course of Alzheimer's disease. So there is deficiency or a problem in new information to be coded in long-term memory. So you will forget who spoke to you in the telephone in the morning. What is the food you took in the breakfast? You can't register or you can't change the information you took in the morning by the hippocampus to the long-term memory. As the disease progresses, you are unable to recall previously learned information, because the atrophy will start in the hippocampus and then will spread all over the brain. So the previously learned information can be recalled, like name of the famous people in the environment, and the visuospatial memory, which is where you are living, which floor you are living, where you are working. So local geographical memory will be disturbed. In advanced cases, the patient can identify people around him, especially near relative, and can't identify himself even when he sees himself in the mirror. This is called misidentification or disorientation of others and disorientation of himself. This is in advanced cases. And this is the memory which is specifically in Alzheimer's disease, and also other cognitive dysfunction, which other types of dementia will share, like unable to do complicated tasks, like cooking, like running his business. Also, when the condition will progress, he can't recognize money, and he can't make decisions like choosing what he needs from the shop during shopping. And in advanced cases, very minimal cognitive tasks he can do, like planning, like many things during the daily activities, like phoning someone using the mobile or using the traditional phone in home. So this is a cognitive disturbance, but in Alzheimer and in other type of dementia, which is called frontotemporal dementia, there is behavioral and psychological symptoms. And behavioral and psychological symptoms in our culture is the main cause of hospitalization and the main cause for seeking help from doctors or asking help from doctors. It occurs in 90% of patients with dementia, and always this is the presenting signs and symptoms. It occurs in Alzheimer's disease and in other types of dementia like vascular dementia, frontotemporal dementia. And these behavioral and psychological symptoms is treatable. You can treat it, and you will know this through treatment of dementia. For example, some of the symptoms will be visual hallucination. This is different from functional disorder like schizophrenia and depression with psychotic symptoms. Usually it will be auditory hallucination, but in case of organic brain syndrome like dementia, it will be visual hallucination. Delusions, okay, especially persecutory delusions, sleep disturbance, aggressiveness, hostility, hoarding, restlessness, all anxiety, depression, okay, elation, apathy. All of these symptoms are usually behavioral and psychological symptoms presented with whatever the cause of dementia. Now, the classification of dementia. You get an idea about some of the classification. As I told you, Alzheimer and frontotemporal dementia, but now we'll put a clear classification of dementia. Number one, usually, as I told you, one of the cardinal feature of dementia in differentiating it from delirium is the irreversibility. The course of dementia is irreversible in 97.5%, but in 2.5% it is reversible. And if you discover the reversible dementia, will save the brain of the patient. So 97.5 will be irreversible and 2.5% will reversible. And there is some causes of reversible dementia like hypothyroidism, like mental retardation. If you treat hypothyroidism early, the patient will not be mentally retarded. Also, if you treat hypothyroidism early in the elderly, the patient will not get progressive dementia. Number two, if vitamin B12 deficiency, if you discover vitamin B12 deficiency early in the course, you will save the brain from dementia. Also, normal pressure hydrocephalus and chronic subdural hematoma. This is the most common reversible dementia. Another landmark regarding the age or concerning the age is the age 65. If dementia occur before the age 65, it is called pre-senile dementia. If dementia occur after the age of 65, it is called senile dementia. This is the second type of classification. Number one, according to reversibility. Number two, according to the age. Number three, according to the pathology. Regarding the pathology, we have degenerative, which is called primary. We don't know exactly the cause, and secondary dementia. Concerning primary dementia, it is Alzheimer's disease, okay, affecting mainly temporoparietal area of the brain, and frontotemporal dementia affecting the frontal and the temporal part of the brain. And the subtype of frontotemporal dementia is called Lewy body dementia. This Lewy body dementia has specific characteristic, which is the patient is usually presented with visual hallucination and very sensitive to the antipsychotic, especially if the patient in the course got behavioral and psychiatric manifestation. So we'll treat the patient with antipsychotic and you will find severe extrapyramidal symptoms. And this sensitivity and visual hallucination give you a mark that the condition is Lewy body dementia and usually associated with Parkinsonian feature. But here the dementia started first and the Parkinsonian feature comes later. This is to be differentiated from secondary type of dementia with its Parkinson dementia complex. The patient usually starts with Parkinsonism, extrapyramidal symptoms, and later he will get dementia. So you have to ask which symptoms started first, dementia or Parkinson feature. If it is dementia, it is Lewy body dementia. If it is Parkinson symptoms, it is Parkinson dementia complex in the secondary dementia. In case of Alzheimer's, the condition usually starts, as I told you, by memory disturbance. If in case of frontotemporal dementia, usually started with behavioral and psychiatric manifestation disturbance. Non-degenerative dementia with the secondary dementia, number one is the vascular dementia. A vascular dementia is called also multi-infarct dementia. It is due to multiple infarction, sizable infarction. Also traumatic causes, which is chronic subdural hematoma. As I told you, it can be reversible if you treat early. And inflammatory dementia, like in case of multiple sclerosis. Also in case of infectious dementia, like due to a venereal disease like HIV and neurosyphilis. So you have to make investigation VDRL to exclude these disorders. When you neoplastic causes like brain tumor, so you have to do MRI, and toxic like chronic alcoholism. Where these metabolic causes like chronic renal failure and the liver cirrhosis, and the endocrinal, very common is hypothyroidism, one of the most common reversible dementia. So you have to do thyroid scanning and thyroid function test. Also nutritional causes like vitamin B deficiency, folate deficiency, which is called Wernicke's or Korsakoff psychosis. There is also secondary dementia due to Huntington's And you can put Huntington's in degenerative, or you can put due to secondary dementia. Parkinson dementia complex, as I told you, it started by Parkinsonism, and then dementia comes later. And normal pressure hydrocephalus, one of the most common reversible dementia if you treat early. But according to prevalence rate, Alzheimer's disease is the most common dementia. It is up to 65 to 85%. And second one is vascular dementia. It is up to 30% of the dementia. And the most common is the mixed type between Alzheimer and the vascular dementia. And after that is the lower body dementia, then frontotemporal dementia, and other causes of dementia like Huntington, normal pressure, and so on. What else? Now we will discuss the most common cause of dementia, which is the Alzheimer's disease. Now, this is the first question in my lecture. A woman presented to the psychiatrist with her husband, complaining that her husband starting to forget the meals, and usually nagging after her, asking for food. Despite that, she took lunch with him, but he can't remember. And usually, during the last 1 week, calling her by another names and deal with her as if she is his sister, not his wife, can't sleep well. And at night, he usually get frightened because he saw strangers in the home, and sometimes he started to be excited, and in the morning he can't remember anything. She thought that it is a transient condition, but after 1 week she got an impression that something serious happened. What's your diagnosis in this case? Memory disturbance, visual hallucination, behavioral and psychiatric manifestation, more worse at night. We are waiting for your answer. Thank you. If you remember the first case, I want to ask you if your diagnosis is correct. What is the differential diagnosis of this case? Also, what is the first step you have to do for proper management of this case? Now, Alzheimer's disease, as we said, it is the most common form of dementia. 65, it's about 2/3 of the cases. And because it is dementia, so it has gradual decline. The term gradual, insidious, is very important. Gradual decline in the cognitive function. And as I told you, there is memory loss. What is memory loss? Recent. The recent information can't change from working memory to long-term memory. So what happened recently, in the course of Alzheimer's disease, you can't remember. But the patient can remember the remote memory, the old memories, very well, till the advanced stage when the atrophy started to be spread from the hippocampus to the other parts of the brain, so the remote memory will be affected, which is old memories. And the clinical diagnosis of Alzheimer's disease, as I told you, it is gradual onset of symptoms. This is one of the cardinal feature. Clear consciousness, to be differentiated from delirium. Irreversible, except in 2.5% it is reversible. And one or more of these significant impairment in the cognitive function. Number one, there is 4 A's. First A is amnesia. Amnesia for the recent memory. Okay? Number 2 is aphasia. Aphasia, the patient can't name very common objects in the environment around him. You can ask him, what is this? He will say, this is what you can use in writing. Can't remember or name. This is pen. What is this? You can drink from it. You can't say that this is a cup of water or glass of water. Okay? And number 3 is apraxia. What is apraxia? The patient's voluntary movement is good. He can move his hand. But he can't do very skillful behaviors like knotting his shoelace or tying his cravat or something like that. Also, agnosia. The patient can see well what is around him, but can't recognize his mobile. When you ask him, can you give me your mobile? He can see on the table, all over the things, the laptop, the mobile, the pen, and he can't recognize his mobile is here. Despite his vision is, visual acuity is good. Also, you can, the patient can present with agraphia. Despite that he can move his hand very well, he can't write. Acalculia, despite he is graduated from the faculty of accounting, he can calculate very primitive numbers. So, amnesia, aphasia, apraxia, agnosia, acalculia, agraphia. One of the very common symptoms is visuospatial memory loss. So the patient can't recognize his home and can't return to his home, can't go to his work as usual, and he will be lost in the street. This is called wandering. Okay? And his function, like cognitive function, like planning, managing his life, which is called the executive function, will be impaired. Also, one of the behavioral and psychiatric manifestation will be visual hallucination and emotional disturbance, like early in the course will get depression and later in the course will get apathy. This is very important. Early in the course because he has awareness of his condition, that his memory is started to be impaired, so he will be depressed, and later he will lose his awareness and the memory of emotions stored in the brain will be vanished, so the patient will get apathy. He will not experience or express good feeling or bad feeling. Okay? And concerning the behavioral disturbance also, the patient will behave not in accord with his social standards. He can joke in front of people in a serious situation. He can change his clothes in front of his children. He asked his wife to do sex in front of children. He can masturbate in the living room. And if you want to diagnose Alzheimer's disease, Alzheimer's disease is diagnosed by exclusion, so you have to exclude other causes of secondary dementia. Okay? And Alzheimer's disease is gradually and progressive disorder. And Alzheimer's disease can be mild, moderate, and severe. And before you diagnose Alzheimer's disease, if you get cognitive impairment and the patient is functioning well, but he started to forget something and his function is not impaired, this is called mild cognitive impairment. And this mild cognitive impairment before the start of mild dementia. This is stage before Alzheimer's disease. There is risk factors for Alzheimer's disease. Age is the most common risk factor. So, by the age of 65, by each 5 years later, the prevalence of Alzheimer's disease and the incidence of the Alzheimer's disease will double. Okay? Also, Down syndrome. Depression is a risk factor. Depression will be a risk factor for Alzheimer's disease because in depression, cortisol will be increased and will attack the hippocampus, which is the starting point of Alzheimer's disease. And depression is a symptom early in the course of Alzheimer's disease. So it may be symptom or risk factor. Metabolic syndrome also, if the patient like obese, hypercholesterolemia, something like that. Smoking also is a risk factor, but the patient usually die before getting this age. So smoking was misperceived as a protection, but it is one of the risk factors if the patient live later above the age of 65. And there is gene called ApoE4, which is responsible for late onset Alzheimer's disease. This ApoE4, if one allele is present, the risk is doubled, and if two alleles is present, the risk will be fivefold. And this ApoE4 is the is responsible about the heaviness of the position of amyloid plaque in the patient, as we'll discuss later. But there is potential protective factor for Alzheimer's disease, like physical activity. This is very important. High IQ and education, still reading, like intellectual stimulation by reading, and food rich in antioxidants is very important as a protective factors against Alzheimer's disease. Alzheimer's disease has 2 or 3 pathological findings. Number 1 is atrophy of the brain, especially in the temporal area, which underlying the temporal area there is the hippocampus and parietal area. And 2 cardinal risk factors after with the atrophy, which is amyloid plaque and neurofibrillary tangles. What is amyloid plaque and what is neurofibrillary tangle? If you see the hexagonal figure of the neuronal membrane is formed from a protein called amyloid precursor protein. This protein, if the cleavage of the protein is correct, part from the amyloid precursor protein will form the neuronal membrane and part will be dissolved in the CSF. If the cleavage is not good, the part which will be dissolved in the CSF will start to be undissolvable. So it will be precipitated near the neuronal membrane. And months after months, year after year, this precipitating amyloid will form plaque, making disconnection between the neuron. That is one of the causes of agnosia, memory loss. You will see something and you will ask the neuron beside it to give the name from the memory associated area, but the disconnection by the amyloid plaque will prevent this connection. So you will see something and can't recognize it, which is agnosia. Will see something and you can't remember it because you can't remove it from the working memory to the long-term memory. So the amyloid plaque is first pathological feature of the Alzheimer disease. And because the precipitation is outside the neuron, it is called extracellular pathology. So amyloid plaque is extracellular, making disconnection between the neurons. The other one is the neurofibrillary tangle. This hexagonal figure of the neuron is due to skeleton, like bones inside the neuron called tau protein. This tau protein, if it is dephosphorylated, it is hard. So it will give you the hexagonal common shape of the neuron. If it is hyperphosphorylated, it will be dissolved and the neuron will be collapsed, and the collapsed neuron beside it will make the brain shrink, and this is the cause of atrophy of the brain. And it is inside the neuron. So tau protein, hyperphosphorylated, amalgamated inside the neuron will called neurofibrillary tangle. It is intracellular. And the amyloid plaques, the precipitation of the amyloid outside the neuron is extracellular. Okay? And we have two neurotransmitters responsible for Alzheimer's disease. One is acetylcholine and the other is glutamate. If acetylcholine is deficient, Alzheimer's disease will occur. If glutamate is in excess, it will cause excitotoxicity and Alzheimer's disease will start. So our targets in the treatment is to increase acetylcholine and to diminish the excitotoxic effect of glutamate. Investigation of Alzheimer's disease, first of all, to assess the cognitive function by many mental state examination and the Montreal Cognitive Assessment Scale. Also lab investigation to detect the underlying organic disease, especially early in the course for reversible dementia, like routine lab investigation, B12 serum level, T3, T4, and TSH, VDRL for venereal disease, also neuroimaging like CT or MRI in case, especially MRI, to discover the brain tumor and the atrophy of the brain, and you have to make it at different time span to discover the atrophy and decrease in the volume of the hippocampus by time. Differential diagnosis of Alzheimer's disease, normal forgetfulness of aging, and the difference between it and Alzheimer's disease, the function is good. Other causes of dementia, will be discovered by investigation. Delirium by the three cardinal features: acute onset, reversibility, and disturbed state of consciousness, which is confusion. Other psychiatric manifestation, which is depression, and if depression is severe in the elderly, can cause depressive pseudodementia, and you have to differentiate between depression, depressive pseudodementia and dementia. And depressive pseudodementia, the onset is acute, the condition is more worse in the morning, and the patient has insight, and there is no visual hallucination. If the depression with psychotic symptoms, it will be auditory, and the patient, if treated well, it will be reversible, and you can read it in your book, other differentiating point. What is the treatment of Alzheimer's disease? You have to treat, if it is a case of dementia, before Alzheimer's disease you diagnose, you have to treat the underlying cause of secondary dementia. But if you reach the diagnosis, it is primary and there is no underlying cause, There is two types of treatment. Non-pharmacological treatment, which is a cognitive enhancing, group therapy, environmental cues for the patient, care for the patient for safety, and attention for the patient for safety. And number two is pharmacological treatment. As I said before, we have to increase the acetylcholine because acetylcholine will be deficient in Alzheimer's disease. How to increase the acetylcholine? By cholinesterase inhibitors. So cholinesterase inhibitors will prevent destruction or metabolism of acetylcholine into acyl and the choline. And the drugs in the market are donepezil, rivastigmine, and galantamine. Previously, there is Tacrin and withdrawn from the market because of the hepatotoxicity. It will not improve Alzheimer's disease. It can give, it can make the course stationary in a rare condition, but it delays the deterioration or slow the progression, and can be used in mild and moderate dementia. The second neurotransmitter involved is glutamate. So we use a drug called memantine, which is NAMDA antagonist, partial antagonist, which means it prevents the excess glutamate from reaching its receptor, which is the NAMDA receptor, so it decreases the hazardous and excitotoxic effect of glutamate. And the drug is called memantine and is used in moderate to severe cases. So acetylcholinesterase inhibitors in mild to moderate and memantine in moderate to severe, and we can combine this in two drugs in moderate to severe cases. If the patient presented with depression, we can use antidepressant. If the patient presented with visual hallucination and delusion as a symptoms of behavioral and psychiatric manifestation, we can use antipsychotic. And we have to use one of the most common used antipsychotic is risperidone and haloperidol, because they have less sedative effect. And this less sedative character is very important because sedation can confuse the doctors that the condition is delirium, because state of consciousness will be affected. So be clearly avoiding the sedating drug, using only risperidone and haloperidol because of lacking sedation. Also, don't forget the caregiver. The caregiver usually develop depression and can go through burnout syndrome, so you have to care for the caregiver. Until now, there is no proven treatment to slow the progression if the case has mild cognitive impairment. If the patient not fulfilling the criteria of Alzheimer's disease, but complaining of memory disturbance and his functioning is good, we don't have prophylactic treatment for Alzheimer's disease. Now we will start the other disorder of organic brain syndrome is delirium. It is not present in mild and cognitive, mild and severe cognitive disorder. It is another disorder in organic brain syndrome. It's called delirium. And as I said before, delirium is differentiated from dementia, that it is acute and the state of consciousness is disturbed. And these two cardinal features named can be used as another name for delirium, acute confusional state, or sometimes we call it acute brain failure. It is usually common due to medical illness, secondary to medical illness, and usually because of the presentation with psychiatric and behavioral changes misdiagnosed as psychiatric illness. And this misdiagnosis will delay adequate medical intervention. And the delirium is life-threatening. So if you can't diagnose delirium, the patient can die. So doctors who can't diagnose delirium is doing malpractice. And if you are working abroad in Saudi Arabia or any Gulf area, if you misdiagnose a case of delirium and the patient misdiagnosed, you will be fired because it is a very dangerous malpractice. So, and also delirium is very common. So you can't be graduated from Faculty of Medicine and you don't know the very common disease in medicine. Nomenclature, as I said, it is acute confusional state, and because ICU is a main site of medical illness and the patient usually present with behavioral and psychiatric manifestation, it's called ICU psychosis. And because it is more worse at night, it's called sundowning. It's called also encephalopathy or acute brain failure or syndrome of cerebral insufficiency. By definition, delirium is transient and reversible and acute and affecting a state of consciousness and presented with a broad range of neuropsychiatric abnormalities and cognitive dysfunction. Okay, so the hallmark of delirium is fluctuation, is disturbed sensorium, and it is life-threatening disease. And in case of delirium, it is very common, 10% of newly hospitalized patient, and if the patient is hospitalized, up to 30% will get delirium, and if the patient doing an operation, up to 50%, and if the patient in the intensive care, up to 3/3 of the cases will get delirium. So it is very common. The most common risk factor is age. If the age is increased, delirium most commonly occur. Also, if the patient is sedated, if the patient is immobile in the bed or physically restrained, if the patient is abusing or dependent or addict on drugs, if the patient have sleep deprivation or over-sedated, have severe pain, have severe illness in the terminal illness, and fever, one of the most common. It is not written in your slides, but fever is one of the most common risk factor of Alzheimer's disease. And all of the disorders with risk factors can cause delirium, and delirium is multifactorial. As regard internal medicine, from the department of endocrinology, you can find it in hyperglycemia, hypoglycemia. You can find it in hypothyroidism, hyperthyroidism, hyperparathyroidism, hypoparathyroidism. In case of renal department, you will find it in impending and renal failure, hepatology, impending and hepatic failure, geriatric because of the aging process and vitamin B12 deficiency, very common in this age. In case of cardiology unit, you can find it out of myocardial infarction and severe pain with myocardial infarction. In case of surgery department, post-operatively, especially in big operations like cardiotomy or open heart surgery, and cancer operation taking a long time because it is highly associated with poor oxygenation and loss of blood. Also, in case of any department like chest department out of the hypoxia or the treatment the patient is taking, in case of neurology department out of the brain affection, in case of brain infarction, in case of brain tumor, in case of orthopedic department, it is out of big operation like hip replacement. So we'll find it whatever you are practicing medicine, you will find delirium. So it is very important. One of the most common cause is drug-induced out of the drug, secondary to the drug, especially anticholinergic drug, sedative drug, antihistaminics, okay, and also the drugs used for psychiatric treatment like antipsychotic because of sedation. The DSM criteria for delirium, number one, disturbed state of consciousness. So we can call it confusional state. Number two, memory disturbance like recent memory disturbance and disorientation. Disorientation regarding a person with time or place. This is a second very common. Number 3 is psychiatric and behavioral changes like visual hallucination. Number 3, it is acute onset. Number 4, it is reversible. And you have to find by examination an underlying cause. And the course and the prognosis, if you treat the underlying cause, the patient will improve. So 50% of the patient will improve. And the condition wax and wane, and don't be confused about waxing and waning and the improvement. Waxing and waning during the course, but improvement, all the disorder improve and the condition didn't recur. Some patients, especially elderly patients, will never return to previous level of cognitive function, and it is very critical disease because this in 25% of the cases. So again, the common feature is cognitive impairment, confusion, acute onset, reversibility, disorientation regarding a place with time with person. The person is present in the hospital and asking to go to the hospital. In the home and asking his relative, I need to be in the home. Calling his wife, and his wife is sitting beside him. He wants to go to the work, and it is 2 a.m. and it's not the suitable time to work. So disorientation, disturbed state of consciousness, attention, especially sustained attention, and memory disturbance, recent memory disturbance. Also the condition may be behavioral changes. The patient may be hyperactive. It's called hyperactive subtype or hypoactive subtype, and the hypoactivity may be to the level of stupor. And we have 4 differential diagnoses of stupor in psychiatry. Number 1, delirium. Number 2, catatonic depression. Number 3, catatonic schizophrenia. And number 4, hysterical. And don't forget sundowning. The condition is more worse at night, and wax and wane of the condition. And this is again the clinical characteristic because it is important. And the delirium have 2 types, as I told you, hypoactive and hyperactive. And the hypoactive can be to the level of stupor. Also, you can test the cognitive function in delirium by many mental state examination. And the most important items in many mental state examination is subtraction 7 subsequently, and the orientation question, and the spelling of word background, and the months of the year background, and the counting down from 20. And you have differentiate now between delirium and the dementia, and this is a table differentiating both of them, and I discussed this with you many times. What is the treatment? Number 1, treatment of the underlying cause. Number 2, before treatment, treatment of the underlying cause, and before it you have to discover the accurate diagnosis of the underlying cause. So you have to diagnose the underlying cause, say to treat the underlying medical condition, then symptomatic treatment as a psychiatrist for behavior and psychiatric manifestation. So number 1 in the treatment of the underlying cause. Number 2 is supportive treatment, environmental intervention, because the patient has disorientation regarding a place, so it is make the environment more safe. Number 3 is symptomatic treatment. If you will give treatment, give antipsychotic, less sedating, like as I told you in dementia, haloperidol and risperidone, and avoid any drug causing the disturbance for cognitive function, like anticholinergic, anti-sedating drug. And in case of visual hallucination and delusion, you can give the patient atypical antipsychotic in low doses, like quetiapine in low doses. Okay? And at the end, thank you for listening to me.